Hello, welcome to this edition of Leading Insights. My name is Jessica Peña, and I'm really delighted to be joined today by Dr. Leslie Cho, a fellow prevention enthusiast and co-author of the recent 2026 dyslipidemia guidelines. So it's really great to be here with you today.
Well, thank you, Jessica.
So a lot of really exciting updates in the new guidelines. For me, one of the most exciting parts is the emphasis on treating earlier. The message that lower for longer is better is really exciting. What about you?
I mean, I completely agree with you. I think the lifetime risk, I think, is a concept that we really need to put forward and embrace, really. For me, as a longtime researcher for lipoprotein little a, I'm super excited that for the first time ever, we're recommending everybody get an LPA level for at least once in their lifetime.
I think one of the important points with LP little a is recognizing it as a risk enhancing factor and really being aggressive about lowering the LDL right now.
Right?
And we know that one of the challenges to achieving goals, and goals are back,
Yeah.
is a statin
Yeah,
intolerance or statin associated muscle
that's
symptoms.
right.
And that's an area that's highlighted in the guidelines. So tell me, what do you think clinicians should know about the approach in those patients?
I mean, I think one of the most exciting things to have emerged is that instead of debating like, is statin intolerance real? It doesn't really matter. Now we have amazing therapies besides statins. Of course, we should try statins first, but we have amazing therapies that have clear cardiovascular outcomes and data behind it that we can talk to our patients about to get them to goal. So aren't we so lucky to live in an era where we have things like PCSK9 inhibitors, bempedoic acid, to really, and Zetia to lower patients to goal.
Yes, I think that's really a key message is really recognizing that we have many different medications available and having that patient discussion,
Yeah,
that shared decision making,
yeah,
I think is also something that's emphasized,
yeah,
is really eliciting patient values, understanding what someone's goals are,
yeah,
and then saying this is everything that we have available.
yeah.
These are expected treatment effects, side effects, and having, being able to tailor therapy. That's important, I think, also because for so long, patients who had statin intolerance or muscle symptoms thought that there was nothing else for
Yes,
them. And so this
yes.
is really a re-education,
Yes.
don't you
And
think?
also think it's a huge leap forward to offer people the injectables as well as an oral compound that shows in cardiovascular CVOT outcomes trial that it lowers events. I think that was the other thing that was kind of dragging the field, right? That you didn't really have great, besides ezetimibe, 7% reduction in MACE, that you had, that you have something else. And now, great, you have a compound that can lower cardiovascular events, primary prevention, secondary prevention. You also have injectables. I mean, I just think that instead of, banging our head against the wall with statins and in to patients who don't want to take statins, here you go. Here's the armamentarium. The discussion should be, let's get you to goal. Let's get you to event reduction so you don't have a heart attack, you don't have a stroke, you don't have vascular dementia.
Yes. And something else I noticed with the guidelines is really engaging lipid specialists for those patients who you do have trouble with,
Yes.
who have had trouble with statin intolerance,
Yes.
and recognition that there are people who can help.
Yeah. I mean, you and I both work in a center where we have lipid specialists. We're so lucky. Oftentimes, patients have to go somewhere else for that. But even if you have to go somewhere, like, now you have all these compounds. So you don't, lipid specialists may be very difficult to find in a center, but, now you can use these other things too. I think the sad statistics that we always quote to each other is that 50% of people are not at goal, you know? And these are high risk patients, still not at goal. Instead of like now banging our head against the wall about statins, let's get them to goal. Let's get them to goal with all these other things.
Yes, and then among high-risk patients, how many stop therapy?
Yeah,
And so
yeah,
that's another point that's emphasized is monitoring
yeah,
to make sure people are adherent or not experiencing side effects, because we know sometimes we don't even know when people right
yeah.
stop therapy,
That's right. That's right.
and
That's right.
so the importance of monitoring over someone's lifetime to make sure that that we treat with what we have
Yeah.
available.
Yeah.
I know you're expert in this area. How do you approach the clinician-patient discussion or that shared decision making in your program?
I mean, we have a huge statin intolerance clinic, and usually they come to see us because they failed two statins, and then we really do a very intense, history taking. Perhaps you were on a statin when you were on something else that interfered with it. We do intermittent statin dosing, and if you can't take it, then we go to all these other compounds that we talked about. I think we have to, in 2026, acknowledge that statin reluctance. You have to acknowledge it and meet the clinician where they're at, and also meet the patients where they're at. And I think it's okay. It's okay to have that long discussion with the patient about the benefits of statin. But if they don't want to take it, okay, great. You have these other things. The goal should be LDL reduction. The goal should be reduction of cardiovascular events. That's the goal, you know?
Yes. And sometimes it takes a long time to have those
Yeah, yeah,
discussions.
yeah,
It's
yeah.
not something that you can do just in one visit.
Yeah,
It's
yeah,
and
yeah,
also, of course, recognizing the importance always of diet and
yeah.
lifestyle.
Okay,
And
absolutely.
many people
Yeah,
want to
yeah, yeah.
maximize those
Yeah,
things
yeah,
before they
yeah.
think about other
Yeah,
therapies.
yeah. I often think that we have this sort of laissez-faire attitude to lipids, like, oh, do diet and exercise, come back to us in 6 months. 6 months go by, they don't follow up. Then it's like a year later, you've lost all that time. I think, of course, diet and exercise as the cornerstone of therapy, but really, following them up closely, 8 weeks. There's no magic to 12 weeks. In clinical trials, we saw them in 6 to 8 weeks. So following them up closely, really sort of treating them to goal when there is, when you initially meet them, so that this is the moment. This is a critical moment where you have to take sort of patients at their, I guess, most enthusiastic, you know, and really sort of challenge them and inspire them and have that sort of patient physician relationship where both of you have a goal and you work towards that goal.
That's really a great point that you make about following them closely and making changes quickly and not letting so much time
Yes.
elapse.
Yeah.
And sometimes we also don't emphasize, or we should emphasize, the importance of treatment variation, how individual responses
Yes.
vary. And
Yes.
so that's
Yeah.
part of the rationale
Yeah.
for, following up with labs or lipids,
Absolutely.
because what we quote are for LDL reduction with many agents are ranges, and
Yes.
there is
Yes.
variation in individual
Yes.
responses for a
Yes.
variety of reasons.
Yes.
And so we always have to really individualize it and explain
Yes.
and see
Absolutely.
what it does for an individual
Absolutely.
patient.
Absolutely. That's a great point.
Well, it's been great talking to you today about something that I know you're passionate about, and I've enjoyed learning from you about your experience. And thank you.
Thank you, Jessica.